Hello everyone, this video is all about psoriasis and I've kept this like nice and simple this time, unlike the utter chaos of the impetigo video, which we won't talk about. Just popping up on a screen now and the things we will be discussing in this video. Psoriasis is a chronic autoimmune condition characterised by the rapid build-up of skin cells, leading to the formation of thick silvery scales and red patches. It's a non-contagious inflammatory disorder that primarily affects the skin, but can also involve the nails and joints. There are a few different types which we will also discuss. Some of the general symptoms then. We have erythematous plaques which are well demarcated with a distinctive silver scale. These scales may flake off easily or become more prominent during flare-ups. Plaques may be itchy, painful, leading to discomfort and irritation, and affected areas of the skin may be dry and prone to cracking. Psoriasis symptoms tend to come and go in cycles, with periods of remission followed by flare-ups, and severity can also vary widely between individuals. Plaque psoriasis is the most common type of all the classifications. The plaques are usually symmetrical and most commonly affect behind the ears, scalp, and extensor surfaces. And there's a clear delineation between normal and affected skin, and it can often accompany nail psoriasis. Guttate psoriasis affects approximately 8% of psoriasis sufferers and presents as small, scattered, round or oval scaly papules, which may be pink or red. It most commonly affects younger adults and children, although anyone can be affected, and it may develop suddenly or be preceded by an infection, example, strep throat. Pustular psoriasis can be generalised or localised. It presents as rapidly developing widespread erythema, followed by eruption of pus-filled blisters. As mentioned, it can be widespread but also localised to the hands and the feet or palm or pointer. The generalised type is potentially a life-threatening emergency and patients should be advised on seeking medical help. This type can be triggered by pregnancy, certain medications such as terbinafine, which is an antifungal treatment, beta blockers and abrupt withdrawal of glucocorticosteroids such as prednisolone. Inverse psoriasis or intertriginous is smooth and shiny in contrast to normal psoriatic plaques and newly erect body folds that may be accompanied by other types of psoriasis at the same time. Some risk factors now. Some of these are higher risk factors for the disease which is classed as modifiable, such as alcohol and obesity, or non-modifiable, for example, with genetic link. Some are also triggers for making the symptoms worse, and these would include the medications listed there, beta blockers, antimalarials such as chloroquine, lithium and ACE inhibitors, for example, lisinopril. So how is psoriasis diagnosed? This is via a physical exam and medical history, focusing on symptoms and symptom progression, family history and history of any immune disorders. You can pause the screen and have a look at this, that it's important during diagnosis to classify the type so treatment can commence. What else could it be? Psoriasis can resemble other skin conditions such as eczema and fungal infections, so these must be also ruled out. Some other possible causes which present in a similar manner are on the screen now. So, on to treatment. This is based on severity, areas of the body affected, and of course patient preference, cosmetic acceptability, and practical aspects of application. If the patient doesn't find the treatment acceptable or too messy, they just won't use it. So the backbone of treatment should always be emollients to repair the skin barrier and help with symptoms such as itching. Next step is a potent or very potent corticosteroid for 4 weeks and then review. If this alone doesn't control symptoms, a vitamin D analog product can be added or a combination product such as calcipotriol with betamethasone. Depending on the area and patient preference, this may be a gel, foam, cream or ointment. The Enstilla foam, for example, is a very good choice for the scalp. For the scalp, an agent to help soften and remove scales can be added as well, such as salicylic acid with coconut oil, available as a shampoo. Or coal tar can be offered, which reduces scaling and inflammation and has an antipruritic effect. This can be combined with other treatments. Coal tar alone for severe symptoms is not recommended, it's just not going to work. If all treatment options are failing at this point, we can offer treatment with short contact dysrenal under a specialist setting. So treatment on the face, fractures and genitals, use a mild to moderate corticosteroid. Here we step down due to the delicate nature of the skin. Short term is best 1 to 2 weeks per month. If no response, then a calcineurin inhibitor can be used under specialist supervision. These do not cause striding. Tacrolimus, pimecrolimus for 4 weeks. Now, for guttate psoriasis, phototherapy can be used under supervision using UVB light, or photochemotherapy, which combines UVA and psoralen, which enhances the effect of the UVA light. Systemic therapy is also worth a mention here under specialist supervision. We have the non-biological treatments such as methotrexate and cyclosporins. Fever used if all else fails, and the impact on the quality of the life is severe. Or we also have the biological types such as interleukin inhibitors and tumor necrosis factor alpha. Here is just a bit more information about all the different types of medication available. Some of the benefits of emollients are listed on the screen now. The potent or very potent corticosteroids, care is needed. Use the least amount possible and review every 4 weeks. Systemic effects can be seen if used on a large surface area, so keep it to a small localised area. Cycling on and off, for example, use for 4 weeks with a rest period in between. Vitamin D products and emollients can be used during this time. Steroid preparations can also cause the skin to atrophy and cause striae, which are stretch marks. This is also why care is important when using these products on the face, as these effects are often irreversible. So a little bit more information on topical vitamin D for those who are interested. It can cause hypercalcemia, so care is needed in calcium metabolism disorders and if the skin barrier is severely dysfunctional. For example, in generalized pustular psoriasis, if the amount absorbed into the systemic circulation will increase. In pregnancy and breastfeeding, there isn't actually any safety data available, so the manufacturer advises avoid. It's also very irritating, so best not to be used on the face. And care is needed in people taking certain medications, such as thiazide diuretics, as they can increase urine calcium levels. Some side effects are also listed there. Vitamin D analogues can also be used where corticosteroids are not tolerated. The 3 available in the UK are on the slide. Coal tar is not to be used on broken or inflamed skin or infected skin or on genitals or rectal area. It's to be avoided in the first trimester of pregnancy, and in breastfeeding, caution is required. The infant must not come into contact with treated skin. It can also stain, irritate, and can cause folliculitis. Diffrenal causes staining, skin irritation and burning, so start with a low strength and titrate up over a period of about 4 weeks from 0.1%. It's a once-daily application to plaques only, avoid normal skin, and then discontinue once lesions are palpably flat. Salicylic acid is not to be used if allergic to aspirin or on inflamed or broken skin, or if there's an acute local infection there, and not to be used on large areas, as there's an increased risk of salicylic toxicity. And as the pregnancy and breastfeeding, no studies have been conducted in pregnancy on topical use. However, such as relatively small proportion is absorbed to the skin, it's unlikely to pose any risk. And on the slide is just an overview of the systemic treatments available as well. Now we have some advice to give to patients then about their treatments and condition. As with many ointments and creams that are paraffin-based, please warn the patient about the fire hazard risk. This is if the product has soaked into fabrics and come into contact with naked frames such as a cigarette. Also advise the patient that topical treatment may take several weeks to start working and that if treatment is stopped suddenly, there may be a risk of a relapse. We need to be realistic with treatment expectations and explain that it's aimed at controlling symptoms and that cure or complete clearance of lesions may not be possible. General lifestyle advice to reduce exacerbations such as smoking cessation, reducing alcohol consumption and weight loss may help a patient. We can also assess for any anxiety and stress that could be contributing and help monitor us appropriately as well. Finally, there are 2 main charities in the UK offering advice and support to patients with psoriasis. Amoeba on the slide.